Ever feel like you just need the absolute core facts on a complex health topic, like right now, without wading through pages and pages?
Yeah, just the essentials. That's exactly what we're aiming for today.
We're doing a deep dive into asbestosis.
We've basically boiled down some MSRA revision notes to pull out the really high-yield stuff. Think of it as your quick guide.
Perfect. So the mission today, get a really solid grip on asbestosis. What is it? How does it sneak up on you? How do we spot it? And what can actually be done about it?
Sounds good. Let's jump in.
Okay, so first off, what is asbestosis in simple terms?
Okay, so at its heart, asbestosis is a chronic lung disease. It's caused by breathing in asbestos fibers over a long period.
Right.
These fibers cause progressive scarring. The technical term is fibrosis in the lung tissue itself.
Darn, okay.
And that scarring makes the lung stiff, less flexible, and makes it progressively harder to breathe. So the key things are long-term exposure, irreversible scarring, and breathing problems.
Got it. And it falls under that umbrella term, pneumoconiosis, is that right?
Exactly, yeah. Pneumoconiosis is the general term for lung diseases caused by inhaling different kinds of dust. Asbestosis is the specific type caused by, well, asbestos fibers.
From work, usually.
Mostly occupational exposure, yes, but sometimes non-occupational too.
And you mentioned it takes a long time to show up.
Oh, absolutely. That latency period is really important to grasp. We're often talking 15, 20, even 30 years, sometimes more, between when someone was first exposed and when they actually start noticing symptoms.
Wow, 15 to 30 years, that's huge.
It is. Symptoms like getting progressively short of breath, maybe low oxygen levels, that delay makes connecting the dots back to the exposure quite challenging sometimes.
I can imagine. And asbestos doesn't just cause asbestosis, right? There are other related conditions.
That's a crucial point. Asbestos exposure is linked to a whole spectrum of diseases. At one end, you have things like benign pleural plaques.
Benign, so not cancerous.
Correct. They're basically markers on the lining of the lung, the pleura, showing there's been exposure, but they don't usually cause problems themselves or need follow-up. Okay.
Then you have asbestosis itself, which is this interstitial lung disease affecting the actual lung tissue with that fibrosis we talked about.
Right, the scarring.
And then, unfortunately, there are the malignant conditions.
Oh.
Mesothelioma is a big one, a cancer of the lung lining, strongly linked to asbestos. And asbestos exposure also significantly increases the risk of developing standard lung cancer, especially, as we'll probably discuss, in smokers.
So quite a range, from harmless signs to very serious cancers. You mentioned different types of asbestos fibers earlier.
Yes, there are a few types.
Yeah.
Common ones are chrysotile, that's often called blue asbestos amosite, and chrysotile, which is white asbestos.
Is one worse than others?
Well, all asbestos is dangerous, but chrysotile, the blue type, has the strongest link to mesothelioma. Chrysotile is generally considered a bit less hazardous in that specific regard, but still causes asbestosis and lung cancer.
Okay. And how do the lungs actually try to deal with these fibers when they're inhaled? Something about macrophages. Right, yeah. So when you breathe these fibers in, your lungs have these defense cells called alveolar macrophages. Their job is to basically clean up debris.
Like little vacuum cleaners?
Sort of, yeah. They try to engulf and remove the asbestos fibers. But the problem is these fibers are sharp and durable. They can actually damage or even kill the macrophages.
Ah.
And when the macrophages get damaged or die trying to deal with the fibers, they release inflammatory signals. This triggers more inflammation, attracts more cells, and contributes to that whole cycle of chronic inflammation and eventually scarring.
So the body's defense mechanism kind of backfires and adds to the problem.
In a way, yes. It gets overwhelmed and the inflammatory response becomes part of the disease process itself.
Okay, that makes sense. So looking at the damage pattern in the lungs for asbestosis specifically, where does it usually show up?
For asbestosis, the fibrosis, the scarring, it typically affects the lower lobes of the lungs predominantly. That's a characteristic finding.
Lower lobes. Good to remember.
Yeah, and remember that 15-30-year latency we talked about? It takes time. And sadly, once that scarring is there, we don't really have treatments to reverse it.
And that mesothelioma you mentioned linked to the blue asbestos.
Yes, strongly linked to chrysotile. It's an aggressive cancer of the pleura, the lining around the lungs. Prognosis is generally poor.
What symptoms might point towards mesothelioma?
Things like shortness of breath, chest pain, sometimes quite severe, and often pleural effusion, that's fluid building up in the space around the lung.
And the lung cancer risk.
Significantly increased with asbestos exposure. And if someone was exposed to asbestos and they smoke or smoked, the risk is multiplied. It's a really dangerous combination, far worse than either risk factor alone.
A synergistic effect.
Exactly.
So stepping back, the basic cause, the etiology, is crystal clear then.
Absolutely. It's the inhalation and deposition of asbestos fibers deep within the lungs. Simple as that.
And it's a chronic exposure thing, not a one-off.
Correct. It develops over time with repeated, usually occupational exposure. Think mining, construction, shipbuilding, insulation work, manufacturing that use asbestos.
So those are the main risk factors, people who worked in those jobs.
Precisely. Occupational exposure is number one. Construction workers, miners, shipyard workers, boiler makers, plumbers, electricians who might have disturbed old asbestos materials.
A lot of trades involved historically.
Definitely. And sadly, even secondary exposure was a risk family members inhaling fibers brought home on work clothes.
That's tough. Okay, let's trace the process again, the pathophysiology. Fibers get inhaled, then what?
Okay, so step one. Inhale the fibers. They're microscopic. They get deep into the smallest airways and air sacs. Step two. They stay there. The body can't easily break them down or clear them all. Step three. This triggers that persistent inflammation we discussed involving the macrophages and other immune cells.
The chronic battle starts.
Right. Step four. Over years, this chronic inflammation leads to scar tissue fibrosis forming around the airways and in the lung tissue. Step five. This scarring makes the lungs stiff, reduces their capacity, impairs the transfer of oxygen into the blood.
And that leads to the symptoms.
Exactly. Shortness of breath, cough, reduced exercise tolerance. It's a slow, progressive stiffening and scarring.
It sounds quite distinct, but are there other conditions that look similar? What are the main differential diagnoses?
Good question. Yes, several other lung diseases can present with similar symptoms and even similar patterns on scans sometimes. We need to consider things like idiopathic pulmonary fibrosis, or IPF.
Idiopathic meaning no known cause.
Exactly. Also, hypersensitivity pneumonitis, that's an immune reaction to inhaled organic dusts, like from moldy hay or birds. Sarcoidosis can sometimes mimic it, and other occupational lung diseases like silicosis from silica dust.
So the exposure history becomes really key in differentiating.
Absolutely crucial. A clear history of significant asbestos exposure is a major pointer towards asbestosis over those other possibilities.
What about the numbers? How common is this in the UK now? Is it easy to track?
It's tricky to get exact prevalence figures for asbestosis itself, partly because of underdiagnosis and that long latency. People exposed decades ago might only be diagnosed now or might be misdiagnosed.
Right.
But we know thousands have been affected due to the heavy historical use of asbestos, particularly in those high-risk industries like construction and shipbuilding.
Are there any firmer stats?
Mesothelioma stats are tracked more closely. In the UK, there are around 2,700 new cases diagnosed each year, which reflects past exposure levels. Globally, the World Health Organization estimates something like 125 million people are still exposed to asbestos in the workplace.
Still, wow.
Yes. And just to reiterate that crucial point, smoking drastically increases the lung cancer risk for someone also exposed to asbestos. Massively.
Okay, so when someone comes in, what signs and symptoms really make a doctor think, could this be asbestosis? What's the typical clinical picture?
The classic presentation is someone, usually older, with a history of potential asbestos exposure, presenting with gradually worsening shortness of breath, especially on exertion.
Progressive breathlessness.
Yes. Often a persistent dry cough, too, maybe some chest tightness. On examination with the stethoscope, we often hear characteristic crackling sounds at the end of inspiration called bibasilar fine-end inspiratory crackles or rails.
Crackles at the bottom of the lungs.
In a good percentage of cases. Finger clubbing, where the fingertips become enlarged and the nails curve, can also be seen, though it's not specific just to asbestosis.
So exposure history, progressive breathlessness, those crackles.
That's the key triad, really. The diagnosis hinges heavily on confirming that exposure history and then matching it with consistent findings on lung imaging, like a CT scan. A lung biopsy is usually not needed.
And you'd be thinking about ruling out those other conditions like IPF too.
Definitely. Need to consider the differentials. The breathlessness starts subtly, maybe just not being able to keep up like they used to, then gets worse. Sometimes a cough might bring up phlegm, maybe some wheezing, but the dry cough and breathlessness are more classic. As it advances, those crackles become more prominent, and eventually it can strain the right side of the heart, leading to cor pulmonale.
Okay, so what investigations are done to confirm it? What tests nail the diagnosis?
It's a combination. Pulmonary function tests, or PFTs, are key. They measure how well the lungs are working.
What do they typically show in asbestosis?
Characteristically, they show a restrictive pattern. This means the total lung capacity, TLC, and vital capacity, VC, basically the amount of air the lungs can hold and exhale, are reduced. The ability of oxygen to transfer from the lungs into the blood, the DLCO, is also typically reduced.
So stiff lungs that can't hold as much air and can't transfer oxygen well.
Exactly. But importantly, the ratio of how much air you can blow out quickly in 1 second, FEV1, compared to your total forced vital capacity, FVC, that FEV1-FVC ratio is often normal or even increased. That pattern helps distinguish it from obstructive diseases like COPD.
Okay, so restrictive defect, low DLCO, normal ratio, useful pattern. What about imaging?
Imaging is vital. A standard chest X-ray might show haziness, particularly in the lower lung zones, maybe signs of pleural plaques, those thickened areas on the lining. But a high-resolution CT scan, HRCT, is much more sensitive.
What does the HRCT show?
It can show the early interstitial thickening, fine lines, sometimes a ground glass appearance early on.
Right.
Later, you can see more established fibrosis, architectural distortion, and potentially honeycombing, which indicates advanced irreversible scarring. It's also better at showing those pleural plaques.
And the occupational history.
Absolutely critical.
Right.
Need to ask detailed questions about past jobs, tasks performed, potential exposure levels, duration.
Any other tests? Biopsy, blood tests.
Lung biopsy is rarely needed for diagnosis if the history and HRCT are typical. Blood tests are generally nonspecific, not helpful for diagnosis itself. On physical exam, besides the crackles, you might find that finger clubbing in maybe 30–40% of cases. Sometimes, if the diagnosis is really unclear on imaging, a procedure called bronchoalveolar lavage, or BAL, might be done.
Like that.
It involves washing out a small section of the lung via a scope and analyzing the fluid. Finding asbestos bodies in the BAL fluid can support the diagnosis, and the levels can correlate with the overall asbestos burden in the lungs.
And if a biopsy was done, what would it show?
Histopathology would confirm a diagnosis by showing both the interstitial pulmonary fibrosis, the scarring pattern, and the presence of asbestos bodies, which are asbestos fibers coated by iron and protein by those macrophages. The pattern of fibrosis in asbestosis is typically different from, say, UIP, the pattern seen in idiopathic pulmonary fibrosis, and often involves the visceral pleura near the plaques.
Okay, so once someone is diagnosed, what's the plan? What's the management strategy?
This is the tough part, because there's currently no specific drug treatment that can reverse the fibrosis or cure asbestosis.
No magic bullet.
No. So management is really focused on a few key areas: relieving symptoms, preventing further damage, and managing complications.
Like what?
Oxygen therapy is often needed if blood oxygen levels are low, either at rest or with activity, to help with the breathlessness.
Okay. What about non-drug approaches?
These are crucial. Number 1 is preventing any further asbestos exposure. That's paramount. Number 2 is smoking cessation, absolutely vital to reduce that massive additional risk of lung cancer.
Makes sense.
Then supportive care. Managing symptoms of breathlessness, perhaps pulmonary rehabilitation programs can help improve exercise tolerance and quality of life. Treating any coexisting COPD or heart failure, like pulmonal. And vaccinations, getting the annual flu jab and the pneumococcal vaccine, is important to prevent respiratory infections, which can be serious in people with lung disease.
Are there any more drastic options? Surgery.
In very selected severe cases, lung transplantation might be considered. But it's a major undertaking with its own risks and isn't suitable for many. If there's a large pleural effusion causing discomfort, draining the fluid thoracentesis can provide temporary relief.
So mainly supportive care, symptom management, and prevention.
That's the cornerstone, yes.
What's the general outlook then? The prognosis?
It's quite variable, honestly. It depends heavily on how much lung damage there is, the duration and intensity of the past exposure, whether the person smoked, and their overall health.
But it tends to get worse over time.
Generally, yes. It's considered a progressive disease, meaning the scarring and symptoms tend to worsen over time, although the rate of progression can vary a lot between individuals. Some might remain relatively stable for years, others decline more rapidly.
And always that increased risk of cancer looming.
Always. That increased risk of lung cancer and mesothelioma is a significant part of the prognosis and needs lifelong awareness.
What other problems can crop up? What are the main complications?
Besides the cancers, the main complications stem from the progressive lung damage. Respiratory failure is a major one, where the lungs just can't provide enough oxygen or remove enough carbon dioxide. Pulmonary hypertension, high blood pressure in the lung arteries due to the stiff lungs can develop and strain the heart.
Leading to that core pulmonale.
Exactly. And having scarred lungs makes people more susceptible to respiratory infections like pneumonia.
It sounds like a really difficult diagnosis to live with. Is there any support or compensation available for people affected, especially if it was from work?
Yes, that's an important aspect. In the UK, individuals diagnosed with asbestosis due to workplace exposure might be eligible for benefits like the Industrial Injuries Disablement Benefit, IIDB.
Okay.
They may also be able to pursue a civil claim for compensation against the employers responsible for the exposure. There are time limits, though usually 3 years from the date of diagnosis or when they became aware the condition was linked to their work under the Limitation Act.
So acting relatively quickly is important if considering a claim.
It is. And beyond compensation, there's the aspect of medical surveillance for those known to have had significant exposure, but who haven't yet developed disease.
What does that involve?
Health and safety regulations, like the Control of Asbestos Regulations 2012 in the UK, require employers to arrange appropriate medical surveillance for workers still potentially exposed or those with significant past exposure. This usually involves regular checkups, typically at least every 2 years, for higher-risk individuals.
What do they check?
Focus is on respiratory symptoms, a clinical examination, and lung function tests, spirometry. Interestingly, routine periodic chest x-rays are generally not recommended for surveillance alone due to the cumulative radiation dose, unless there's a specific clinical reason to do one.
Okay, so monitoring focuses on symptoms and function.
Yes, trying to pick up early signs of disease developing.
Right, so let's quickly recap asbestosis. Serious chronic lung scarring from inhaling asbestos fibers, often showing up decades after exposure.
Primarily lower lobe fibrosis.
Diagnosis relies on that exposure history, plus characteristic findings on PFTs, that restrictive pattern, and especially HRCT scans showing fibrosis and maybe plaques.
Don't forget the bibasilar crackles on examination.
Right. And management is supportive: oxygen, smoking cessation, vaccinations, managing symptoms, as there's no cure for the scarring itself.
And always bearing in mind that significantly increased risk of lung cancer and mesothelioma.
Absolutely. Recognizing those risk factors and the potential lung latency is so important.
Definitely key takeaways.
And for all of you listening who are preparing for the MSRA, if you want to cement this knowledge and cover other high-heel topics, do check out pastthemsra.com for more resources.
And don't forget the free content available too over at freemsra.com. Lots of useful stuff there.
Definitely worth a look.
And maybe a little memory aid for asbestosis. Just think. Awful scarring begins. Eventually. Slowly tightening oxygen supply inside. Something like that.
A sickening breath, exposure takes over slowly. I like it. Helps tie it all together. Definitely something to keep in mind. Great stuff, thanks.
You're welcome. Early recognition and prevention are key in occupational health.